This is CCTA case number 12. It's a 78-year-old man with atypical chest pain and an abnormal treadmill exercise test. There are 3 phases presented in here. We have the Cine controls. We can change the phases by pushing the forward button into these 3 areas. Let's start looking at the left main first of all. Put this in the crosshairs. Left main appears to be quite normal. Proceed into the left anterior descending artery. Put this in a foot view, and proximal vessel appears to be quite normal. But as we get near the mid portion of the vessel, in the mid portion of that, here's the first diagonal, so this would be theoretically the mid left anterior descending, we can see that there is clearly some mixed plaque involving calcified as well as non-calcified, with a very long tubular narrowing in this region. We can make an estimation by doing some two-dimensional idea of how long this lesion would be. It measures about 13.4 millimeters. Using old-fashioned cath lab information, anything longer than 1 centimeter or 10 millimeters increases the likelihood of hemodynamic significance, but this looks to be quite focally obstructive. If we follow down the remainder of the left anterior descending, vessel appears to actually be quite normal. Let's take a look at some other areas. Let's focus on the circumflex artery coming off about here. We can then drag down to see if we can get a better view of that vessel. Actually very normal looking, very small ramus intermedius coming off, and then an obtuse marginal vessel coming off in this area. Can change again phases to be sure that you're getting the best view. This appears to be probably the best view for that vessel. Appears to be normal. Let's look at the right coronary. Get the right coronary up here. Rotate around. Vessel likewise appears to be quite normal. We can change the phase to see if that helps a little bit. This phase seems to be better for evaluation of the right coronary artery, which looks very normal. Let's get down into the distal segment of this. Very normal. We have a posterior descending coming away here, which also looks very normal. So in this patient we have a focal obstructive tubular narrowing of mixed calcified and non-calcified plaque involving the mid left anterior descending. There are a couple other features here to pay attention to in the overall evaluation of the patient. Let's get up here to a little bit higher cephalad. Here we are at the root of the aorta. You want to take a look at the left atrium, and basically it's you need to act like an M-mode echocardiogram. Basically you need to look at the moderate excursion in this area that would involve a parasternal view that would be sort of what we call the ice pick view on echocardiography. So we want to look at the largest excursion, and then we can go and make a two-dimensional measurement, making an attempt to follow through on a parasternal axis view here. We can get a general estimation of the size of the left atrium. I'm getting almost 50 millimeters in here. It could be smaller, it could be slightly larger, but it clearly is mildly to moderately dilated. One final thing is we can look at the thoracic aorta. If we focus on that, we can rotate this around. This is a normal size vessel, very common to see some diffuse plaque involving the thoracic aorta. Frequently it can be complex, but nothing other than probably moderate calcified plaque in this region. So this patient has focal obstructive disease and is mid-LAD, a dilated left atrium, but would then need to go on for confirmation and cardiac catheterization and likely intervention with angioplasty and stent placement.